Good evening, our colleagues and professors. We will start our 8th event on behalf of EMOG Group. As you know, our EMOG Group is a pure scientific group under establishment as NGO in Egypt and some Middle East countries. We will start today our prostate cancer event. We have today a great faculty of speakers and experts. We have from Egypt different university and different experience. We have Al-Qasr Ain University School, Professor Muhammad Abdullah. We have also Ain Shams University expert and speakers, Professor Muhammad Yassin, Professor Muhammad Al-Hifni, Professor Ahmed Gaballa. Also, we have experience from Alexandria University, Professor Muhammad Farouk. All of them are well-known figures as speakers, especially in prostate cancer in Egypt. Also, thanks Janssen for supporting us and inviting Professor Ahmed Bah, consultant of clinical oncology, Bristol Hematology and Oncology Center, who are more interested in breast and urological cancer. Also, we have a great honor to, in this meeting, to be chaired by Professor Lubna Azz Al-Arab, Professor of Clinical Oncology and Nuclear Medicine at Ain Shams University. For all our attendees, if you have a question, please put the question in the Q&A section to be introduced by us for our speaker and expert. So the mic for you, Dr. Lubna.
Thanks, Dr. Ahmed. Good evening, dearest professor and colleague. First, I'd like to congratulate the Eastern Mediterranean Oncology Group for its scientific activity. May all the professors find the session useful and full of knowledge. Let me start off by introducing my dear colleague, Professor Ahmed Gaballa. Professor Ahmed Gaballa is the president of this group, and he will introduce a very interesting topic related to risk stratification and the option of management in early cancer prostate. The floor is yours, Professor Ahmed.
Dr. Orna, thanks a lot for this presentation. Really, it is an honor to have a presentation for my lecture by my dear professor mentor, Professor Lubna. Allow me to share my screen now. You are seeing my screen?
Yes. Not yet.
Okay.
Yes.
Okay. Actually, event today, I'd like to talk with you about the early prostate cancer risk stratification and its clinical implications. This is the usual traditional slide in all my presentations in all the fields of oncology. Every cancer patient, whatever the origin of the disease, should be discussed in an MDT meeting. So there is no single physician or single doctor decision for cancer patients, especially prostate cancer patients. You should implement the MDT in case by case. Each patient should have the chance to be discussed in MDT meeting before starting his treatment. I have some definitions for early prostate cancer I'd like to highlight before starting the core of the presentation. We should know these expressions. PSA density, which means the baseline PSA before treatment, divided by the pre-treatment volume of the prostate. And we have the PSA doubling time, which is the time needed for the PSA to reach the double number. So, for example, if the patient started with PSA of 4, when he will reach to 8. This is very important. And we have the castration level of testosterone. The castration level of testosterone agreed is less than 50 nanogram per milliliter. And then we have what's called the Gleason score. For a long time, this score was something I can't understand from an oncological point of view. And then I read it in depth. Gleason scores mean that we read the pathology, we assess the prostate cancer specimen pathologically And in the core biopsies we can see many different grades of the tumor inside the lab. The most commonly presented pattern is called the first pattern, and the second most commonly is the second pattern. And we sum the first and the second pattern to reach to the total Gleason score. Each score is graded from 1 to 5. So the first score can be from 1 to 5, and the second score can be also from 1 to 5. And then we differentiate the prostate cancer into well-differentiated tumors where the Gleason score is 6 or less, moderately differentiated Gleason score 7 or 8, and poorly differentiated Gleason score 9 and 10. This is the histological pattern of the different Gleason grades. In the first picture here, you can see grade 1 and 2. Grade 1, you will see almost all the specimen is consisted of well-formed glands with minimal stroma. Grade 2, we have well-formed glands, but still we have more stroma inside the specimen. So this is 1 and this is 2. And we have Gleason 3. Gleason 3, almost 50% of glands and 50% of stroma. And we have Gleason 4, which is minimal glands or cribriform glands. This is the cribriform glands, and this is minimal gland presentation. And the Gleason 5, where we cannot find any gland inside the specimen. And then you have to, the most common and the second most common, and you add them together to reach to the Gleason score of the patient. We have the staging of the prostate cancer, which is well known, and the 7th and the 8th edition. Actually, there is no great difference between the 7th and 8th edition of TNM staging of prostate cancer. T1, which means that this is accidentally discovered prostate cancer, whether during surgery for benign lesion or due to elevated PSA. If it is incidentally during benign surgery, it is T1A or B, according to the percentage of cancer we detected in the specimen. And if it is detected due to elevated PSA, it's considered T1C. Once we have a detectable tumor inside the prostate and it is confined to the prostate, this is considered T2. Previously, it was T2A, T2B, and T2C, and now it is called T2 only. And then we have T3 disease, where we have extracapsular or seminal vesicle infiltration, and T4, which is a locally advanced fixed prostate cancer. We have the well-known the Amicu risk classification of localized prostate cancer, which was came out during and published in the JAMA 1989. This data came out from more than 1,800 patients, and they stratify patients into 3 main categories: the low-risk patients, and in these patients, they found the failure rate is less than 25% within 5 years. And we have the intermediate risk group, which has a failure rate of 25 to 50% within 5 years. And we have the high risk group with a failure rate of more than 50% within 5 years. The low risk group included PSA less than or equal to 10, Gleason score well differentiated tumor, Gleason score 6 or less. And we have an early clinical stage of stage 1 or stage 2A. 2A means just one lobe of the prostate is involved by the tumor. And we have the intermediate risk, which is PSA from 10 to 20, Gleason 7, or clinical stage T2B. If the patient has one of these criteria, he is considered intermediate risk. And we have the high risk group. If this any of these criteria is present, the patient is considered a high risk, PSA more than 20, Gleason score 8 or more, and clinical stage T2C or 3A. Actually, we were working on this stratification long time, until I think 2014, until we have the International Society of Uropathologists meeting, which was held in 2014 and published in 2016 in the journals, based on the Epstein pathological grade grouping discussed in this meeting. They included more than 30,000 patients. Sorry? They included more than 30,000 patients with prostate cancer, and they grouped the Gleason scoring into 5 different groups. The first group is Gleason 6, which is 3 plus 3. And we have a 96% 5-year biochemical relapse-free survival. with definitive treatment with a surgery or radiotherapy. And we have the group 2, which is Gleason 7, but Gleason 7 with a primary grade of 3. And the relapse rate is very low, less than 12%. And we have the Gleason 7 group 3, which is composed of 4 plus 3. The primary component is 4. And we found there is a great difference in the biochemical failure. Here it is 63% compared to group 2, which is 88%. And we have group 4, which is Gleason 4, 4 plus 4, with 48% of relapse-free survival. And we have the poorly differentiated Gleason, which is 9 and 10, with complete lack of glandular differentiation, with 26% only of biochemical relapse-free survival after definitive treatment. Based on this new classification, we had the new risk stratification of prostate cancer patients, early prostate cancer patients. And this risk classification were adopted by the NCCN, WHO, ASTRO, American Urologist Association, and Southeastern Urology Group. In all their guidelines, they included the new risk stratification. They included the very low risk. The very low risk included the PSA of less than 10, grade group 1, which means Gleason score of 6 or less, and the clinical stage T1C. Actually, this is exactly the low risk group of the Amicu classification, but they added 2 more conditions to include the patient in this group, very low risk. The first is to have a PSA density of less than 0.15 nanogram per milliliter per gram, and to have less than 1/3 of the core biopsies we got from the prostate involved by the tumor, and no core involved more than 50% by the tumor. If you have the low risk criteria with these 2 additional conditions, so the patient is classified as very low risk. And then we have the traditional low risk with PSA less than 10, grade group 1, which is Gleason 6 or less, and the clinical stage T1 or T2A, like the Amicu classification exactly. And we have the intermediate risk. It is like the Amicu classification, T10 to 20, grade group 2 or 3, which means Gleason 7, and clinical stage T2B or T2C. But in this new stratification, they classified the intermediate risk group into 2 further groups. The favorable intermediate risk group, which include an early Gleason score of 6 or less, but the PSA is slightly elevated more than 10, but less than 20, or they are within the grade group 2, which means Gleason score 7, 3 plus 4, with PSA low less than 10. If the patient has one of these, so he is a favorable intermediate risk. Other than these 2 conditions, so he is unfavorable intermediate risk. And then we have the high risk group, which is T3A, grade group 4 or 5. But in 5, the only permitted grade group 5, which means Gleason 9, is only 4 plus 5. The primary score is 4. And we have PSA more than 20. These patients are considered high risk. And we have the very high risk, which is considered locally advanced, whether with fixed prostate in T4 disease or seminal vesicle infiltration in T3P, or we have a primary Gleason pattern of 5. So we have 5 plus anything. This means this patient is a very high risk, even if it is 5 plus 3. Or we have a grade group of 5, which means Gleason 9 or 10, other than 4 plus 5. Or we have Gleason score 8 or more in more than 4 core biopsies of the prostatic biopsy. And we have the metastatic disease, which is definitely with N plus or M plus. Then during the treatment of to build up the decision of treatment of prostate cancer patient, you should know the expected survival of the patient. So in the States and in Europe, they have what's called the life insurance tables and the Minnesota Metropolitan Life Insurance table, which is available in the States, and the WHO life tables, which is classifying patient survival by country based on the data they received from the countries. And then they add or subtract 50% from this data if the patient is within the normal or the average group. So the calculated or expected survival is kept the same. But if the patient is in a very good condition, doing sport, very good quality of life, very good performance status, you can add 50%. But if the patient is having a lot of comorbidities like diabetes, hypertension, cardiac disease, so you can subtract 50% of the expected survival. I adopted from the WHO the table of Egypt. This is the expected survival of Egyptian population from the WHO website from the year 2010 till the year 2015. So for example, if you look for a patient of 65 to 69 years, the expected survival is around 13 years. This is the average. And if the patient has a lot of comorbidities, you can subtract 50% of this. So the expected survival will be around 7 years only. And if the patient is in very good condition, so you can add 50% more, so the expected survival will be around 20. But the average is 13. So from this table, you can get the expected survival of your patient before taking the decision of the treatment. You will see later how it is very important. So what is the available options of treatment of early prostate cancer localized disease? We have the very traditional observation. Observation is offered for the patient who are frail, who they cannot withstand definitive treatment, whether with surgery or radiotherapy. Actually, this option is offered for the patient to keep the patient in the best quality of life without affecting their quality of life or exposing them to a lot of toxicities. No active treatment is offered for the patient. Even the androgen deprivation therapy is not allowed to be offered for the patient. We continue only to symptomatic monitoring of the patient. PSA monitoring can be done also, but not so frequently, maybe once every 4 to 6 months. And once we found a lot of progression, whether symptomatic or with much elevation in the PSA, we can start only palliative androgen deprivation therapy. This is the meaning of the observation management. So with observation, from where the concept of observation arises, actually this was aroused from the data published by Johansson in JAMA 1997. He made a population-based trial in the Swedish population. He offered the patient with observation only for early disease, T node or T2, and he found that the survival at 15 years of follow-up was 89% without any treatment, and the progression-free survival at 15 years was 85% with observation only. So from this, we have a valid option for our patients, which is called observation. And then we have active surveillance. Active surveillance actually is completely different than observation. Active surveillance, it contains a lot of active management. Active management does not include treatment, but include a lot of investigation you are doing to the patient, but without giving him a definitive treatment. The benefit of this active surveillance is to avoid unnecessary treatment, and the pitfalls, you may take a lot of biopsies from the patient, you have risk of bleeding, fibrosis, and later on, this fibrosis may lead to difficult surgery if you need to perform surgery for the patient later on. What is a component of active surveillance? It should include initial accurate staging and systematic biopsy with ultrasound, multiparametric MRI, MRI-guided biopsy. Routine PSA and digital rectal examination should be offered for the patient. A second confirmatory biopsy should be taken within 2 years from the first biopsy. And if you took a few cores less than 10 in the first surveillance biopsy, or you have a reading discordance, you should take a second biopsy within 6 months from the first biopsy. You may also ask multiparametric MRI frequently during the active surveillance. And once the patient develops adverse reclassification, whether PSA elevated, the Gleason score changed, there is features in the MRI of progression. So active treatment should be started immediately, whether with surgery, radiotherapy, brachytherapy, whatever. The active surveillance came out from a lot of trials. The most important trial of them is the PROTECT-T trial, which randomized more than 1,600 patients into active treatment, whether with radiotherapy or surgery or active surveillance. And they follow up the patient for a long time. Actually, this data was published in the New England Journal of Medicine in 2016. After 10 years, we found that the prostatic cancer specific survival is identical in the three groups. This means that the patient who received nothing has the same survival like the patient who received active treatment with radiotherapy or with surgery. And we have the progression-free survival for surgery and radiotherapy almost the same, but with active surveillance, definitely the progression-free survival was much less, and this was statistically significant. We should know some from this trial. This trial included about 23% of patients with high Gleason score of 7 or more, means moderately differentiated or poorly differentiated tumors. We have in this trial 17 deaths only, which represent 1% of the population died due to prostate cancer over 10 years. 8 of these patients, half of them, was in the active surveillance group. And if these 8, 5 of them had a high Gleason score of 7 or more. So we can say that the active surveillance included 50%, and 50% of these 50% had a high Gleason score. In this trial also, we got some toxicity profiling data suggesting that surgery had more sexual and urinary adverse events, and radiotherapy has more rectal adverse events. Based on this is the guidelines of how we are treating our patients. If you have a very low risk patient, you can offer him active surveillance. If his survival is very long, more than 20 years, you can offer him active surveillance versus the definitive treatment either with radiotherapy or surgery. And if the patient is shorter survivor of 10 to 20 years, so active surveillance is the only valid option in this group of patients. And if your patient is surviving less than 10 years, I think observation only without any active management or any active investigations is a valid option. So in very low risk patients, observation is valid if the patient survival is less than 10 years. Also in the low risk group, still if his survival is less than 10 years, observation is a valid option. And if his survival is more than 10 years, active surveillance is still valid for him based on the PROTECT-T trial. And in the favorable intermediate risk group, which means that the Gleason score of sleep 3+4 or 6 or less, but the PSA is slightly elevated from 10 to 20. If the patient's survival is more than 10, active surveillance is still a valid option based on the PROTECT-T trial. And if the survival is less than 10 years, you can observe the patient, or if the patient prefer, you can start for him radiotherapy. But we will see later that surgery is not a valid option for this group of patients with survival less than 10 years. For the unfavorable intermediate risk, there is no rule for active surveillance, but only if the patient is a short survivor, observation can be offered for him. So let's go for the second option of treatment for this early stage patient, which is the radical prostatectomy. This option is a very good option for patients younger than 65 years and with an expected expected survival more than 10 years. Older patients, actually in the trials of surgery, older patients more than 65 had a worse morbidity with high incidence of permanent sexual and incontinence problems. From the data also, we found that open and robotic assisted surgery has same cancer control rate, but the robotic assisted surgery has better morbidity and better or less blood loss. Nerve sparing surgery is better as it provides better erectile function recovery for our patients. We have this important trial which randomized patients for radical prostatectomy versus watchful waiting, which is the old synonymous for active surveillance, with patients for localized prostate cancer. This is a Scandinavian prostate cancer trial published by Bill Axelson in Journal National Cancer Institute in 2008, the 12-year follow-up. In the 12-year follow-up, actually, if you see here, the overall mortality, it is identical. He subgrouped the patient into radical prostatectomy versus watchful waiting, whether the patient is above or below 65. you can find here that the great difference or the great benefit was for the patient younger than 65 underwent radical prostatectomy. But if you look for the patient of older than 65, actually the radical prostatectomy versus active surveillance are identical in the curve. So this great difference is in the younger group underwent radical prostatectomy. And the updated data also of 18 years follow-up by Bill Axelson, published in New England Journal of Medicine 2014, you can find that there is a great difference here for survival in all the patients. And this difference is more evident even in the patient younger than 65. If you look here for the patient older than 65, actually the difference is not that much. So for the whole population, we need to operate 8 patients to rescue a life of 1 patient. But for younger patients less than 65, you need to treat 4 patients only to save 1 life of prostate cancer patient. For the low risk group and intermediate risk group, actually we can find the difference. The surgery actually matter a lot. But for the high risk group, actually we have the same survival between the 2 groups. So surgery didn't get a lot of benefit for this patient who is high risk. And we have the updated data of 23 years follow-up published in New England Journal of Medicine. And in this data, we have a 2.9 years absolute survival benefit for the patient. And we found that if the patient has an extracapsular extension, he has 5 times more risk of death. And if he has a higher Gleason score of 7 or more, this risk of death is 10 times more than if the patient has a well-differentiated tumor. So to sum up, surgery, if you are going to operate the patient, if you took the decision to operate the patient, there is no rule for neoadjuvant therapy. Never to give the patient androgen deprivation therapy before surgery. This is not allowed. And when to perform pelvic lymphadenectomy for your patient with localized prostate cancer. Actually, we have a lot of guidelines, and we have the NCCN cutoff value of expected lymph node metastasis of 2%. If you have an expected lymph node metastasis of 2% or more, please go for pelvic lymphadenectomy for your patients. From where we can get this expected lymph node metastasis, there is a lot of nomograms. The most commonly used is the Parton's nomogram with a predictive accuracy of 0.74%. And we have the Memorial Sloan Kettering Cancer Center nomograms with a predictive detection of about 0.76%. Actually, this is Memorial Sloan Kettering Cancer Center nomograms of 3 parameters. You take the baseline PSA of your patient, the clinical stage, the baseline Gleason, and you take the points score of here. And if the patient has a sum of more than 65, this means that he has a probability of more than 2% to have pelvic lymph node metastasis, and he should go for pelvic lymphadenectomy. And these 3 parameters only nomogram get a predictive accuracy of 0.76. And in the same nomograms, they added 1 pattern only, which is the number of lymph node incidents published in the literature. So you have the baseline PSA, the clinical stage, the Gleason, and based on this, the literature say what is the probability to have lymph node metastasis. And you got the score, and if you have a score of 100 or more, so this patient has a lymph node metastasis probability more than 2% and should go for lymphadenectomy, and this predictive accuracy is 0.78. Actually, this data of the cutoff value of 2% of NCCN was validated in this trial published in the Prostate journal. They used the 2% cutoff value, and they found that by using this 2% cutoff probability, we avoid 22% unnecessary pelvic lymph node dissection with the cost of missing only 3% of our patients with positive lymph node. So what about radiotherapy? I'll go fast through the radiotherapy as my colleague, Dr. Hefni, will discuss it in depth. Actually, radiotherapy is a valid option for low-risk patients. For low-risk patient, we can give single modality, whether external beam or brachytherapy. External beam with or without brachytherapy is another option for the favorable intermediate risk. For unfavorable intermediate risk, you can offer the patient a short course androgen deprivation therapy of 4 to 6 months with the radiotherapy. And for the high-risk patient, you should offer the patient 2 to 3 years of androgen deprivation therapy in the form of neoadjuvant, concurrent, and adjuvant therapy. External beam radiotherapy usually consider hypofractionation. And nodal irradiation is not routine at all. You should exclude the nodal irradiation. The combined modality definitely will increase the toxicity, especially the sexual function toxicity, and some systemic side effects like hot flushes, like increased lipid profile and disturbed lipid profile. Patient with non-malignant obstructive disease, I think surgery is the best for them. But if the patient prefers to go for radiotherapy, please don't give him brachytherapy, as this will increase the obstructive symptoms. External beam radiotherapy with brachytherapy has the same side effect of proctitis and erectile dysfunction, but the brachytherapy has more obstructive symptoms. So avoid in the patient with huge prostate. There is no add value in the published literature of proton therapy for prostate cancer. So what is the principle of external beam radiotherapy? The old 70 gray is no more valid. You should give escalated dose more than this. Minimally, the patient should receive 75.6 to 79.2 for low-risk patient. And you can escalate until 81 for intermediate and high risk. And this only improved the biochemical failure rate, but not overall survival. The combined modality with androgen deprivation therapy has a better disease-free survival. From where we got the data of hypofractionation, alpha over beta of prostate cancer is usually from 1 to 4 grays. So this is the justification for hypofractionation. You can get high fraction size. So we can give a fraction of 2.4 to 4 grays over 4 to 6 weeks, better than instead of the conventional fractionation of 8 weeks. Adjuvant therapy for high risk group after radical prostatectomy, the dose is usually between 64 to 72 for patient with extracapsular infiltration, positive margins, and vesical infiltration, or postoperative detectable PSA. The external beam radiotherapy volumes is the prostate cancer with or without the seminal vesicles for low-risk patients, but it is better for higher risk, intermediate or high, to include the seminal vesicles. What is the other options for localized disease? The whole gland cryotherapy. Actually, the whole gland cryotherapy is approved by the FDA. It provides the same results of the low-dose radiotherapy, which was previously used of 70 gray, and they have the same 10 years survival rates like the low-dose radiotherapy. It can be considered for low and intermediate risk patients who are not eligible for surgery or radiotherapy, and they should have a good life expectancy of more than 10 years. They have the same progression-free survival as the non-escalated radiotherapy of 70 gray, as I told you. But we don't have a survival data about this approach. It is a valid approach. It is used in certain institutes and centers, certain centers around the world. It is not a standard of care yet. But with this modality, we have a high risk of urethral sloughing, especially if the patient underwent previously transurethral resection for benign disorder. We don't have data about the neoadjuvant value of neoadjuvant hormonal treatment in this group of patients. And definitely the patient will have erectile dysfunction. We have a high risk of urinary toxicity, incontinence, irritation, obstruction after this procedure. We have another modality of treatment, which is the HIFO, high intensity focal ultrasound. It is approved by FDA, but there is no clinical evidence. We don't have a definite benefit, not eligible for patients with multifocal disease. It is something like the radio frequency we use for the HCC patients. Some locations in the prostate are not eligible for this technique, like the apex of the prostate, because if you do this, you will make severe bladder injury. So it is just, I think, an option to know, but don't generalize for your patients. So let's look back for the guidelines of how we are treating our patient. If the patient has a very low risk, and his survival is less than 10 years, please go for observation. And if his survival is between 10 and 20 years, active surveillance is the only valid option. Only for patients with long survival, more than 20 years, you can choose between the three choices: active surveillance, external beam radiotherapy or brachytherapy, or radical prostatectomy. You should discuss with the patient the risk and benefit of each approach and take the decision all together with the surgeon, radiotherapist, medical oncologist, and the patient. The patient should be part of your decision. And active surveillance if the survival is between 10 and 20, and if the survival is less than 10, observation only. This is for the very low risk patients. If the patient is low risk and survival is more than 10 years, you have the valid three options again. And if the less than 10 years, observation only. If you have a favorable intermediate risk, if the survival is less than 10 years, observation is a valid option. And radiotherapy also, because we discussed before, no value of radical prostatectomy if the survival is less than 10. Expected survival is less than 10 years. And if the expected survival is more than 10 years, we have the three option as a valid option. And in the unfavorable intermediate risk group, you have observation only if the patient survival is less than 10 years. And if the patient is more than 10 years, you should offer him active treatment with radical prostatectomy or radiotherapy. And active surveillance is not valid option for this patient with unfavorable intermediate risk group. For high-risk patients, combined modality with radiotherapy, androgen deprivation therapy for 2 to 3 years is a category 1 evidence, and this is the preferred modality of treatment for this group of patients. And if the patient would like to go for surgery, yes, it is a valid option, but you should discuss with your patient that adjuvant radiotherapy is there after the surgery. Mostly he will receive adjuvant radiotherapy, and a lot of cases also will receive adjuvant hormonal treatment after surgery. By this, I'd like to thank you for your time, and I hope
Dr. Ahmed, for your comprehensive talk touching a very important topic related to new risk classification. Thank you, Ahmed.
Thank you.
Thank you. Now I have the honor and the pleasure to introduce our dear guest, an eminent figure in the field of oncology, international speaker, our dear guest, Professor Amit Baha. Professor Baha is a professor, is a consultant clinical oncology and the clinical director based at Bristol Hematology and the Oncology Center, with a special interest in breast and urological cancer, and he is widely regarded as international expert in all aspects of breast cancer, especially the new modality of treatment, including proton therapy. He is actively involved in research into breast, prostate, bladder, and pineal cancer, and has more than 100 publications in this research area, and have several presentations, national and international meetings. We have the honor and the pleasure to introduce our valuable speaker, Dr. Amit. He will introduce metastatic hormone-sensitive prostate cancer current treatment. The floor is yours, dear professor.
Thank you very much for your very kind words, and it's a real pleasure to be able to join you all, albeit virtually. And as I was saying, I do miss my trips to Egypt, and not just the trips, meeting really friendly colleagues, but I have to admit I miss the food as well. And hopefully one day we will all be able to be together in the meeting. But it's a real pleasure to be able to talk on metastatic hormone-sensitive prostate cancer. And I actually really enjoyed the previous talk, because I think it is very important to understand that sometimes we do over-treat in early prostate cancer with very minimal benefit in survival terms. But in metastatic hormone-sensitive prostate cancer, these are my disclosures. But in metastatic hormone sensitive or hormone naive, or now also called castration sensitive prostate cancer, things really needed to change because ADT alone, which had been the mainstay of treatment for many decades, and I've always said that ADT has been a blessing and it has been a curse in prostate cancer management. Because ADT is so effective initially, it made us think that many patients can be managed just with ADT alone. Whereas actually in breast cancer, hormone therapy, whilst being effective, is not as effective as ADT, even in ER positive disease. And so there have been more advancements. And because of that, actually, we have now seen over the last 7 to 8 years, significant advances in metastatic hormone naive prostate cancer, starting with Charted and then Stampede with its various arms and Latitude with abiraterone, and recently with Arches and Enzamet, enzalutamide, and Titan with apalutamide. So from ASCO 2019, with the results of almost all these studies having been discussed, the options became ADT plus docetaxel based on Charted and Stampede, or ADT plus abiraterone and prednisolone, or ADT plus enzalutamide and ADT plus apalutamide with Titan. If we look at upfront docetaxel, the meta-analysis of the 3 trials, Charted, GTOG15, and Stampede, shows an absolute 9% overall survival benefit at 4 years. And actually, this is more than the survival benefit that is seen with chemotherapy in breast cancer. However, despite this significant advancement, the uptake of chemotherapy remained low in metastatic hormone-naive prostate cancer. In fact, the real-world data from US, also presented at an ESMO meeting last year, showed that the uptake of docetaxel remains lower than 30%. And the data from Scotland and the National Prostate Cancer Audit in UK suggests a similar figure around 25%. And this is when there were no other additional novel hormonal agent options. Now, when we look at the meta-analysis of upfront abiraterone in metastatic hormone-naive prostate cancer with Stampede abiraterone arm and Latitude, the registration study, then there is an absolute 14% overall survival benefit. This is at 3 years compared to the chemotherapy benefit at 4 years of 9%. This is 14% benefit. So very significant advantage in overall survival. But the question that comes is, can we compare these trials? Because this is the big question. Should the patient get chemotherapy or should the patient get a novel hormonal agent like abiraterone or apalutamide or enzalutamide? And which one of them should they be getting? The problem is we cannot compare these trials. If we look at the chemotherapy trials, you can see that actually these trials enrolled different patients. So de novo patients were highest in Stampede, but in Charted and GTOG, there were patients with prior local therapy, and de novo patients were less. And of course, the split of high volume and low volume was different in these trials. So clearly, we are not comparing like with like. The other question that comes is, does disease volume matter? And as you would know, that initially when the Charted trials were reported, the concept came along that we should be adding treatment for high volume disease, but possibly not for low volume disease. But that actually is not true. Disease volume is of importance only for consideration of radiotherapy for low volume disease. And I'm sure all of you know the difference between the volume definition and the risk definition. High volume and low volume is not the same as high risk and low risk, though there is a significant overlap. High volume is more than or equal to 4 bone metastases, with at least one being in the extra-axial skeleton or visceral metastasis. And high risk means 2 out of 3 risk factors of Gleason score 8 or above, 3 bone metastasis, and measurable visceral metastasis. It is important to point out that retroperitoneal lymph nodes are not considered visceral metastasis in this definition of high volume disease. In the STAMPEDE radiotherapy arm, what we saw was in the low volume patients, defined as those with 3 or less than 3 bone metastases on a bone scan, there was an improvement in overall survival by addition of radiotherapy to the primary disease in the prostate. But in high volume, there was no such difference. Now, if we look at Titan, which is the ADT plus apalutamide study versus ADT plus placebo, we know that the overall study resulted in an improved overall survival, and I'll discuss that in detail. But I just want to point out the high volume and low volume patients in this study had a very similar hazard ratio, all the same. So based on that, the question about disease volume comes into context in the sense that these trials were not designed to answer the volume question. So therefore, the trials need to be considered as a whole. And what we've seen from STAMPEDE post hoc analysis is that the treatment impact is constant in high volume and low volume disease, or high risk and low risk disease. Therefore, in systemic therapy decision making, the disease volume should not be the question. The question should be, do you consider the disease to be significant enough for it to be causing the potential death of the patient in their lifetime? Or does the patient have significant comorbidities, which means that they would not have a extended survival and therefore they do not need additional treatment? So systemic therapy decision should be based on disease parameters with the expected survival, but not on the volume of the disease. Only role for volume is on the decision making regarding radiotherapy to the prostate. So now focusing in detail on the Titan clinical trial. Titan has been described as an all-comer study population. And the reason it is described as an all-comer study population is because these were patients who had presented with de novo disease, or patients who had had treatment, primary treatment, radical treatment, and then developed metastatic disease. They were allowed to have had docetaxel if they were receiving it for MHSPC. And these patients were stratified according to the Gleason score and prior docetaxel, and they were randomized to ADT plus apalutamide 240 milligrams daily versus ADT plus placebo. What is important is the dual primary endpoints. And I would always urge you to look at trials regarding their endpoints and the strength of the statistical calculation. A trial with a dual primary endpoint actually needs a much robust statistical positivity rate for it to meet its endpoints. And whereas compare that to the, say, for example, the ENZAMET and ARCHES trials, you'll find that in one of the trials, the primary endpoint was overall survival, and in the other trial, the primary endpoint was radiological progression-free survival. Whereas in the apalutamide trial, Titan, both overall survival and radiological PFS were co-primary endpoints, therefore, in my opinion, making it robust statistical design. And the secondary endpoints were meaningful, as in clinical practice: time to cytotoxic chemotherapy, time to pain progression, importantly, time to chronic opioid use and skeletal related events. But what was important also in sequencing concept is the exploratory endpoint of second progression, so-called PFS2, and I'll go into detail regarding that. Just to give you the overview of the Titan study, as you can see in the interim analysis was presented with median follow-up of 22.7 months. And because the study was positive with an improved overall survival, the study was unblinded and placebo patients were allowed to cross over to the apalutamide group. And you would imagine that actually with the crossover, the potential difference between the apalutamide arm and the placebo arm would diminish after the crossover was allowed. So we look at that, and this is the demographics of the study. And as you can see that the Gleason score less than or equal to 7 was a third of the patients and 2/3 were 8 or more. About 78 to 80% patients were those who presented with de novo disease, and 22% were those who presented with previously localized disease and then developed metastasis. And about 10 to 12% patients had received prior docetaxel. So the radiological PFS, when reported in the first interim analysis, showed a reduction in the risk of radiographic progression or death by 52%, meaning a hazard ratio of 0.48 and a very statistically significant p-value. And this benefit was consistent across subgroups. And I think this is the important thing, that the high volume and low volume disease hazard ratios were 0.53 and 0.36. And irrespective of whether the patient presented with de novo metastatic disease or with metachronous metastatic disease, having had previous treatment for the primary, the hazard ratios were highly statistically significant. And even though the confidence interval just crossed 1, but you can see in the prior docetaxel use, the consistency of effect shows that across all subgroups, there was a consistent benefit seen. So this is the primary analysis results of overall survival and radiological progression-free survival at median follow-up of 22.7 months. And the overall survival benefit, I'll just point out to you, the hazard ratio was 0.67, which means the risk of death was reduced by 33% at the interim analysis or primary analysis results at 22.7 months, after which crossover was allowed. And then now the final analysis results, which are presented at ASCO GU in February earlier this year, shows that the hazard ratio is actually 0.65. This actually implies that earlier treatment is better. You will not catch up by crossover techniques, so by delaying starting of apalutamide. And if one was to censor the patients who crossed over, then actually apalutamide plus ADT reduced the risk of death by 48%, meaning a hazard ratio of 0.52, if you look at it that way. And the treatment effect favored apalutamide plus ADT across all the pre-specified subgroups. And as you can see, for overall survival, there was similar benefits in hazard ratios in low risk, high risk, in metastatic stage at diagnosis, whether de novo or metachronous metastatic disease. The important aspect is quality of life, which is not just about improving survival, but health-related quality of life. And I'm sure all of you know that in trials, when the health-related quality of life questionnaires are done, they are actually done by patients who have not progressed, because after they progress, they stop doing the quality of life questionnaire. Why am I emphasizing that? Is because if a patient is on ADT alone and has not progressed, then to see that quality of life with addition of apalutamide is maintained, that is a very important aspect. So this is not difference in quality of life because of progression or no progression. This is difference in quality of life or maintenance of quality of life in patient groups who have not progressed. And that means addition of apalutamide did not add to the quality of life burden for the patient. And so we have a treatment with an improved survival, improved radiological PFS, and maintained quality of life. Of course, we need to look at the adverse events, and the safety is very important. And the important aspect here is that the treatment events that led to treatment discontinuation basically were about 11.8%. So roughly speaking, 1 in 9 or 1 in 10 patients may need to stop the treatment. But importantly, the other side effects like fractures and falls and ischemic heart disease, which we knew from the non-metastatic CRPC studies, there was no difference seen from the non-metastatic CRPC studies. So the important aspect is that we need to maintain the patient's general health, their bone health, their cardiovascular health. Even when they start ADT, that should be our prime aim, not just when they start other agents as well. Skin rash gets talked about quite a lot, but actually in the Titan study, the discontinuation of treatment because of skin rash was only in 2.5% cases. That means in 1 in 40 patients. And I think that was a learning experience. As I have used more and more apalutamide, my learning of management of the skin rashes has improved significantly. And I think oncologists are really well placed to guide their patients. We have used TKIs, we use monoclonal antibodies in various cancers, and skin rash can be a common phenomenon. Educating the patient, informing them, and we can have a discussion regarding antihistamine and steroid creams if required. But that is an important aspect because I've now got some patients who come back and say, I didn't get a skin rash. Do you think I'm benefiting from the treatment? And I have to explain to them that that doesn't necessarily mean that they would not benefit from the treatment. So when you look at this is just the graph showing the serious adverse events and treatment emergent adverse events. And you can see that the main difference is in the skin rash and in the fractures, but remember that this is also based on duration of treatment, and patients are longer on the apalutamide arm than on the ADT arm. So the conclusions were that the final analysis of Titan, after a median follow-up of approximately 4 years, confirmed that apalutamide plus ADT consistently improved overall survival with a reduced risk of death by 35% compared to placebo plus ADT in a broad population of patients with metastatic CSPC. And if you adjust for crossover, because almost 40% of the placebo patients crossed over to receive apalutamide at the preliminary result analysis declaration, the risk of death was reduced by 48%. That's a hazard ratio of 0.52. And it had a consistent benefit in other endpoints, including delayed castration resistance and maintained health-related quality of life with an acceptable safety profile and no new safety signals. So coming to PFS2, because one of the reasons to consider this is some people would have argued that, well, what about subsequent treatment? But remember that if any trial shows an improvement in overall survival, it automatically implies that whatever you do subsequently does not add up to giving a benefit to the placebo arm, which will be more than the experimental arm. PFS2 means time to second progression from the first randomization. And I've actually written to guideline committees to say that we should be calling PFS2 composite PFS, because otherwise some people confuse PFS2 to imply time from first progression to second progression, which is not the case. PFS2 is composite PFS, meaning time from first randomization to second progression. And when we see the Titan analysis of PFS2, you'll see that apalutamide plus ADT arm after first progression and then going on to subsequent treatment did better than placebo plus ADT going on to the second treatment and then progression. Why have I got the slide of time to castration resistance? That is because not only from the Titan study, but also from the Stampede trial, it is coming out very clearly that ADT alone, the time to castration resistance is about 1 year. And this is important because if some people feel that due to costs, they would delay the treatment with the novel agents till the patient developed castration resistance, actually the benefit after castration resistance is proportionately reduced. But importantly, median time to castration resistance is 1 year. So you will end up using these agents or other novel agents in a year's time. So why not start using it at the time of diagnosis to maximize the benefit for the patients? Now, if you look at PFS2 in the Titan study based on the second treatment as to whether they had subsequent hormone treatment, meaning predominantly with abiraterone after apalutamide, or whether they had taxane-based chemotherapy. And you can see in both these subgroups, now these are post-hoc analysis, there was an advantage of PFS2 within the apalutamide arm compared to the placebo arm. So apalutamide plus ADT reduced the risk of second progression or death regardless of hormonal or taxane therapy as the next subsequent life-prolonging therapy. One of the concepts is why does that happen? So what has been done is that subsequently they have looked for AR aberrations at baseline and then at progression. And what has been seen is that AR aberration is higher when a patient progresses on ADT alone, whereas AR aberrations at end of treatment was lower in patients who received apalutamide plus ADT. This is still not fully proven, but it lends the concept to subsequent treatment with abiraterone, and I think lends the concept of PFS2. So ADT plus apalutamide may be most effective prior to development of AR aberrations is coming out from this analysis. So the question that comes in everyone's mind is which drug in MHSPC? And of course, the important thing here is that it depends on the team looking after the patient, the expertise of the clinicians, the management of the patients, everything put together. But I think the PFS2 benefit, the all-comer populations in the Titan study, the dual primary endpoints, the maintained quality of life is very supportive of use of ADT plus apalutamide. And if we look at all the phase 3 trials in metastatic castration-sensitive prostate cancer, and we put them in order of their hazard ratio from lowest to the highest, one thing is quite clear that the chemotherapy hazard ratios are actually not as good as the hazard ratios of the androgen receptor targeted agents. And even in that, you can see that the abiraterone hazard ratios are better overall. But remember that the Latitude study was only in high-risk population. But Titan was 0.67 in the interim analysis, but was 0.65 in the final analysis, and adjusted for crossover was 0.52. So just gives you credence to see the hazard ratios and try to discuss what you would think would be the most appropriate treatment with the patient. My point is very simple, that while several questions still remain unanswered in metastatic hormone-sensitive prostate cancer management, however, ADT alone in M1 disease in a fit and eligible patient is not an appropriate option. And I would go as far as saying that it is not an ethical option either. If they are unfit and they have got significant comorbidities, that is a different issue. But otherwise, why should it be the case that we are denying them treatment? Particularly when you look at the guidelines, these are EAU guidelines, but you can look at any international guidelines, ASCO, any other guidelines, which actually give a very strong recommendation for patients. For chemotherapy, the recommendation is very specific that it is de novo metastatic disease. But for ADT, combined with Abi plus prednisone or apalutamide or enzalutamide, one could use it based on the Titan study and the license based on all-comer population. Abiraterone in the EU is licensed for high-risk disease, and enzalutamide is not yet licensed for metastatic hormone-sensitive prostate cancer in the EU. So apalutamide does have that license. And for radiotherapy, I'm sure the subsequent speaker will talk about radiotherapy in this regard, and that is an aspect also to be discussed. So there are challenges. We've made a lot of progress, but there are challenges, and that's why I enjoy these meetings, because it helps us all come together and look at these challenges to try and improve. And our main role is to tailor the treatment for these patients. We have to counsel them regarding the available treatment options. And I think we need to impart the knowledge that ADT alone should not be considered standard of care in this setting. And we need to learn to manage the adverse events. And multidisciplinary care is a key to success. And I think we need to realize that the patient should be at the center of our attention, and the support from the urologists, oncologists, specialist nurses, and the additional team will improve the outcomes for these patients. Thank you very much for your attention.
Thank you, Professor. Elegant presentation, updated data. Now we have, can I ask a question, please, related to what is the rationale behind local radiotherapy in metastatic cancer prostate? In low volume.
Yeah. So it's a very good question. And actually, I have said that we have done the wrong trial, basically, because we have based it on conventional imaging, and we have used low volume as a surrogate for response to treatment. What I would say is that in my practice, I don't worry whether it is low volume or high volume in my decision-making regarding radiotherapy as well. What I do is that after you have given them started systemic therapy, if the patient had had a PET scan at diagnosis, and then you repeat the PET scan and you find that the metastatic disease has all responded exceptionally well to treatment. In fact, you get a complete response in many cases, but you notice that there is still remnant activity in the prostate, right? Yes. And then I would say giving radiotherapy to that as the rationale of eradicating disease or controlling disease which has some resistance to the systemic therapy. What happened is, because we used the conventional imaging, we found that low volume benefits, but that's not because low volume benefits. It's just that more patients with low volume have a better response to systemic therapy, and less patients with high volume have a better response to systemic therapy. We should be either doing a trial where we look at PSMA PET responses after start of systemic therapy and then randomizing them to radiotherapy or no radiotherapy to see that. But I would say that actually if you do a PET scan and you see a complete response or a near complete response in metastatic sites, but residual disease in the primary, then why would you not treat the primary?
Okay. Another
question to
Dr. Mohammed?
Yes, please. Thank you, Amit, for your, as usual, presentation. We used to hear a lot from you. But just one question. Always we are asked about ADT plus Abi or ADT plus docetaxel. We don't have head-to-head trials, just we have better insights from our practice, okay? But in Egypt and in most of the world now, we are much concerned with the economic problems, as you know, okay? So my question is, why we are overwhelming the economic and consider it as something should not be talked about in scientific meetings, but why we consider that Abi is much indolent than docetaxel. When we go to the toxicity profiles of the chemotherapeutics, for me and for you and for all of the attendees, to see what we have from the docetaxel as a side effect that would alter the daily life of our patients, a hematological or something like that, we used to deal with safely. And usually patients are not going to be suffering a lot. But with Abi or any of the ARTA, we are talking about metabolic syndromes. And don't forget that we are talking about elderly, frail population. They have hypertension, they have. And don't forget the drug-to-drug interactions associated with the ARTA. It is not there for the docetaxel. So this is not only enough to justify the use of docetaxel upfront in patients with high volume disease.
Yeah, no, very valid points. And I agree with you. And all I am saying is that ADT alone is not enough. I'm happy if people, but what I'm also saying is that I agree with what you've said wholeheartedly, but the real world evidence is showing us that the use of docetaxel is less than 30% in this population. So this is real world evidence. And this is from US, this is from UK, where data is reasonably well reported, you see. And these are patients who have been referred to the oncologist. I'm not even talking about the patients who have not managed to come to the oncologist. So if you were looking at the total population, the reality may be that it is actually less than 20% with metastatic hormone sensitive who are getting upfront docetaxel. Now, there may be several reasons. I think with the best will in the world, I don't believe that more than 50% patients would be candidates for upfront docetaxel because of their comorbidities, etc. And whilst I agree with the metabolic syndrome problem, the metabolic syndrome predominantly is because of ADT, not because of addition of Abi or anything. And in fact, the steroids used with chemotherapy are much higher dose and they give a much bigger insult over a period of time. But, all I would say is that I would like patients to get ADT plus something. And that plus something has to be either chemotherapy or abiraterone or apalutamide based on the decision and the economics, etc. But one thing is coming out from the Stampede trial, and unfortunately, you're right, we will never have a head-to-head comparison of docetaxel and abiraterone or any other novel agent. In fact, next year or in ASCO, we'll be hearing a preliminary data of combination of docetaxel with androgen receptor targeted agent. And maybe then that discussion would not really be relevant as to which one is better. The idea would be give both. I don't know. I mean, I kind of know, but I'm not going to say anything. But so I have to say that there are patients in whom, if they are willing, they want to complete their treatment within a short course of time, like 18 weeks, 6 cycles of docetaxel is useful, whereas with these other agents, it's continuous therapy. But the important aspect that's come out from
excuse me for just one silly question.
But one thing from sorry, carry on.
Yeah. Just can you hear me?
Yes.
Yeah, just one silly question. Yes, I know it's a very old question, but when the text 327 came to publication, I was not impressed at all by the survival difference in the curve between the weekly and the every 3 weeks. Sometimes the weekly would be more pleasant to the patient. And I feel that we do overwhelming the toxicity profile of docetaxel and always playing as the role of Mr. Hyde, while for the ARTA to be Dr. Okay, I think we have something not explainable, because if you are going to tell your patient that you are going to receive such a treatment for this period of time, but for the ARTA they are going to receive for a very long time. I'm not pro chemotherapy, I'm not against ARTA, but I am telling that, and you know definitely, that all patients, most of patients are diseased already before the prostate cancer. And they have hypertension, they have. ADT will add, and definitely the ARTA will add. So it's a way how to combine.
You're right, but you see the hazard ratios are suggesting that the ARTAs have a better survival benefit. We don't have direct head-to-head, but as the updates from Stampede are coming through, we know that the chemotherapy advantage is actually diminishing over a period of time. But the question is not one or the other. I've always said that the patient needs to be prepared that whatever we do first, there is a sequencing strategy in place, because we cannot cure these patients and we have to explain that it has to be one after the other.
Okay,
yes, I know from prostate cancer, sorry, Lubna, just one word. From the Stop Prostate Cancer meta-analysis that we have 6% advantage in favor of the ABI at 3 years. Does it justify its use upfront?
Well, I think the important aspect is the cost effectiveness modeling, and it's not about whether it justifies its use upfront. The question is, does it justify its use at any stage of the disease? And actually, it probably is less impactful in cost effectiveness terms in the later stages of the disease than in the earlier stages of the disease. And what we shouldn't forget, and I know I've talked to you many times and I appreciate and really respect your views, but what we shouldn't forget is that the first 2 to 3 years after diagnosis, if the patient can be kept fit and active, they actually contribute a lot more to society and family compared to what they contribute when they are in the CRPC stage. So I believe that, and this is one of the problems with the nice cost effectiveness modeling, it does not take societal cost, meaning what is the cost to the society. So if a person is able to continue working or look after their grandchildren or do some activity, that doesn't come in the cost effectiveness modeling, you see. It's only the cost of the drugs and the blood tests and the scans.
Thank you very much. I'm sorry for interrupting you. You were my friend, the man of chemotherapy before. What happened to you?
No, I'm not saying, I have not changed that. I keep on saying that it would be, in my opinion, the wrong thing for a patient to die of metastatic CRPC without the patient who's fit and who has not been able to avail both ARTA and chemotherapy.
Okay.
You know?
Thank you very much.
Thank you, Professor Amit, for your valuable remarks. Please keep with us for discussion till the end if you have a time. Would you please? Now I have the honor and the pleasure to introduce my dear colleague, Professor Mohammed Farouk. Professor Mohammed Farouk is an eminent figure in the field of oncology with a special interest in cancer prostate. Dr. Mohammed Farouk is a professor in Alex University. It will introduce oligometastatic prostatic cancer. Dr. Mohammed.
Shukran. Thank you, Dr. Lebna, for this very kind introduction. And I have to thank actually the Eastern Mediterranean Oncology Group. I have to congratulate them and thank them for their kind invitation. My topic today is a little bit different topic. It is an interesting, evolving topic, talking about the oligometastatic disease in prostate cancer. And actually, we have evolving data about the oligometastatic disease in different oncological situations. In the upcoming 20 minutes, I'll give you some definitions about the oligometastatic prostate cancer. What are the evidence beyond the treatment of the primary in the presence of this oligometastatic disease, and what is meant by metastatic directed therapy, and what are the evidence we have, and I will conclude. First of all, how to define oligometastatic prostate cancer, and we are all familiar with this slide. It's the Hillman's definition in 1995. It is an intermediate state of cancer spread between the localized and the widespread metastasis, and it is nearer to the localized rather than the widespread metastasis. We have actually different scenarios. We have the synchronous oligometastasis, metachronous oligometastasis, oligorecurrence, and oligoprogression. As regards the synchronous oligometastasis, it describes the clinical scenario in which the oligometastatic disease is detected at the time of the diagnosis of the prostate cancer. Metachronous oligo means the development of oligometastasis after treatment of the primary tumor. Oligorecurrence, oligometastasis in the setting of controlled primary tumor, and oligoprogression, progression of the limited number of metastatic deposits, while all the other metastatic regions are controlled under systemic therapy. In order to understand the concept of the oligometastasis, we have first to visit the old theory of the seed and soil by Paget, which states that all the metastatic subclones are present here in the primary tumor, and that it usually goes to the lymph nodes or to the metastatic sites according to two important things. First, the cytokines coming from the tumor, and number two, the microenvironment which is present here in the lymph node or in the metastatic site. If we assume that each metastasis which is present in the lymph node or in the metastatic site will have its own new subclones, and it will be able to produce and metastasize these subclones to another metastatic sites, thus hitting the oligometastasis and hitting the lymph node with an aggressive therapy, which is meant by the metastasis-directed therapy, may lead to improvement in the outcome. Whether this improvement in the outcome was in the form of improvement in the progression-free survival, overall survival, or even delaying the use of androgen deprivation therapy for better quality of life, all these are important aims. Back to the definition of oligometastasis, and of course, it depends on several factors: the number of the metastases, the imaging modality you are using, and even the tumor biology. We don't know whether it has its own tumor biology or not. These are 6 important publications about the oligometastasis, and in all these publications, the definition was it is less than 3 or less than 5. So the development of 3 or fewer non-castrate lesions outside the prostate, usually in the bone and soft tissue, is considered the oligometastasis. The oligometastasis depends on the modality of imaging you are using. If it is the current methods, the bone scan and CT, remember that it has low sensitivity and specificity for detection of the early metastasis. We have newer modality like whole body MRI and like the PSMA and PET scan, which is enabling us to detect more and more early metastasis. And we have this example from this small trial, 45 patients only. And in these 45 patients with high risk locally advanced disease or localized disease, Gleason score more than 8, Capra score 5 or more, PSA more than 15, and all of them in the usual current imaging modalities were having no Mets, but by the PSMA scan, N1 and M1 were detected in nearly 56% of the patients. So it is very important to know what is imaging modality I'm using and what is the best imaging modality for detection of the oligometastasis. What about the tumor biology? Do we have different biology in oligometastasis than in the polymetastatic state? Actually, we have smaller trials. This small trial, for example, is a trial including 34 patients with oligometastatic disease. All of them received radiotherapy, and after 3 months, they were followed up and grouped into 2 groups, those who still having oligometastasis in one group and those who developed the polymetastasis in another group. RNA were extracted and microRNA signature were done for all these patients. And actually there was 2 groups, group signature for the oligometastasis and group for the polymetastasis. But I think that this trial needs to be confirmed in a larger studies. The natural history is very important. In this small trial, 74 patients, median follow-up 10 years. Look at the 5-year survival, 70% for those who are having less than 5 metastatic sites versus 45% for those who are having more than metastatic sites. But again, it is retrospective studies. Now, what about the management of the primary? What is the role of radical prostatectomy as a treatment primary in oligometastatic prostate cancer? We have this data from the EAU guidelines 2020. Radical prostatectomy, offer radical prostatectomy to highly selected patients with T3P, T4N0, or any clinical N1 disease, only as a part of the multimodality therapy. But we have several retrospective data, and I think this is one of the most important of them. This data showing there is improvement in overall survival for patients who underwent radical prostatectomy. Of course, it is retrospective. It includes 8,000 plus patients. In 7,000 plus no treatment, in 245 patients, radical prostatectomy and radiotherapy in 130 patients. The 5-year survival is better for those underwent radical prostatectomy or brachytherapy versus those who are having no treatment. But again, it is retrospective and is subjected to different biases. We are waiting for the trombone study in the UK, which will be published soon. Radical prostatectomy in addition to lymph node dissection plus standard of care versus the standard of care in patients with oligometastatic disease, and we are waiting for other trials evaluating this in a prospective manner. What about the evaluation of role of radiation in patients with limited metastasis? We have this, of course, phase 3 trial. So we have level 1 evidence radiotherapy to the primary tumor, this STAMPEDE study. As you can see, more than 2,000 patients, 40% are having low metastatic burden. The randomization standard of care versus standard of care and the radiotherapy with different schedules given to the prostate. The primary outcome was overall survival. And for those with low metastatic burden disease, it is a pre-planned analysis. Actually, there was a significant improvement in overall survival and in progression-free survival. Going to the metastatic treatment of the metastasis or metastatic directed therapy or the MDT, can we cure patients or even improve the survival or delay the morbidity with the systemic therapy by targeting these oligometastases? Actually, we don't have phase 3 randomized trials, but we have these guidelines, the AEU, again, 2020. Currently, there is no data to suggest an improvement in overall survival. Systematic review highlighted that this approach till now should be considered experimental. But we have different approaches. We have the stereotactic ablative body radiotherapy, we have this lymph node resection, and we have systemic therapy given to the metastatic sites. Of course, we are now familiar with the SAPR-COMET study, very important study, including only 99 patients from different diseases, from different malignancies. All of them were having 5 metastatic disease. 16 only of these 99 patients were having prostate cancer. Randomization, radiotherapy, here is standard of care with radiotherapy to the metastatic sites versus the standard of care. And as you can see here, significant improvement in the progression-free survival and improvement also in the overall survival, although it didn't reach the level of significance. But look at here, 28 months versus 41 months, and here 6 months versus 12 months. Then focusing on prostate cancer, we have the STOMP trial, phase 2 randomized trials, only 62 patients, again, small number of patients, and the randomization or the primary endpoint was the time to the androgen-dependent therapy, and the surveillance versus metastatic directed therapy, which was radiotherapy in 25% of the patients, surgery in 6 patients, and the other 31 patients just surveillance. And as you can see, the median time to androgen deprivation therapy was 13 months in the surveillance group and 21 months in the MDT group. And with the most recent ASCO 2020 update, the 5-year androgen deprivation therapy free survival, 8% in the surveillance group compared to 34% in the metastatic directed therapy group. And the 5-year castration-resistant prostate cancer free survival was even higher in the MDT group, although it was not statistically significant. What about the third trial, which is called the ORIOL trial? This trial, again, phase 2 randomization, observation versus stereotactic ablative radiotherapy. The number is 54 patients, 1 to 3 oligometastases. All of them had previous definitive treatment to the primary, no androgen deprivation in the last 6 months, and randomization SAPR versus observation. The endpoint was the time to the disease progression survival at 6 months and at 12 months. And progression at 6 months was 61 in the observation group versus 19% in the MDT. Progression-free survival, 5.8 months observation versus not reached in the MDT. But do we need systemic therapy for these patients with oligometastatic disease? Actually, as you can see, one retrospective and one prospective trial, in all these trials, 50% of the patients received androgen deprivation therapy. So we cannot even conclude whether this data is due to the androgen deprivation therapy or due to the metastasis-directed therapy. And in this advanced prostate cancer consensus conference, which was held in 2017, 85% of the voters voted to the use of androgen deprivation therapy in addition to the metastasis-directed therapy, and in 50% only they voted for shorter ADT than longer ADT. What about the use of docetaxel in addition to ADT in this group of patients? Again, we are talking about the high volume and the low volume. And as you can see, the oligometastasis is nearer to the low volume, of course, than the high volume. And as the docetaxel in the charted trial, there was no significant improvement in survival for low volume disease. I don't think that the addition of docetaxel is going to benefit these patients. Are we now facing a new state, a new phase, a new category in between the locally advanced disease and the disseminated hormone-sensitive disease? Actually, we don't know. We have to put these patients into clinical trials, clinical randomized trials as regards the number, as regards the modality of imaging, as regards the biology, in order to reach what is, whether the oligometastatic status is a real status, a unique status in between the locally advanced and the disseminated hormone-sensitive disease or not. And here is my conclusion. Prostate cancer has become a flagship for oligometastatic paradigm due to the relatively indolent disease course and early detection of the metastatic disease using the PSA screening and advanced imaging. There is increasing evidence of an oligometastatic state, which is an intermediate state between the localized and the polymetastatic disease, in which patients may experience prolonged survival with multimodality combination of local and systemic therapy. because of oligometastatic prostate cancer encompasses a variety of the disease biology, the optimal management of the oligometastatic disease remain unclear. Systemic therapy remained the cornerstone of treatment for patients with metastatic disease, but several studies demonstrates benefit to the integration of the local therapy to the prostate and the metastatic sites. Further studies are needed in order to identify the genomic and the clinical pathologic features to better select patients most likely to benefit from metastatic directed therapy. And thank you for your time.
Thank you, Professor Muhammad, for your elegant presentation and very interesting topic related to oligomet. Now we have time for discussion. Can I ask, please, Dr. Muhammad? Now, gallium PSMA is affordable, available, and all retrospective data depend on conventional study. In oligomet, would you recommend plasma before starting, especially radical prostatectomy, local therapy, like that, or your opinion, please?
Excellent question. Actually, yeah, this is the recommendation. We have to do PSMA scan before doing, before considering this patient an oligometastasis. As I mentioned to you, in the study of a locally advanced disease, 50% of the patient were having metastatic disease at that time, and it was locally advanced. So by the conventional imaging studies, if we have metastasis, if we did plasma scan, of course, we will be confronted with a more wider and wider spread metastasis. So I recommend plasma scan for earlier detection of oligometastasis and confirmation that it is really an oligometastasis in the presence of detection by another imaging modalities.
Okay.
Can I have a question, please, Dr. Lubna?
Yes, sir. Would you please?
Yes. Yeah, the naughty guy. Okay. Thank you, Muhammad. I know you did your best in this presentation, but actually what I feel that we have a quite crowded floor.
Yes.
We have three overlapping definitions.
Yes.
We have oligometastatic, we have low volume of disease in part, and M0 CRPC.
Yes.
Yes.
Okay. We have shared a lot of data between them. Let us try to clarify. When you will tell this patient is really an oligometastatic disease, and this patient is metastatic, hormone sensitive, low volume, and this will be M0 CRPC.
Yes.
Which of them should vanish from the stage, in your opinion?
والله هو a very difficult question, very important question actually. هي الفكرة
also to my friend Amit Bal.
يعني هو دكتور أميت لو موجود يبقى it's very nice to hear from him first. The overlap between the definitions.
Well, thank you, and I know those are questions that we are all grappling with. I'll share my opinion. On the question about whether to do a PSMA PET scan in a patient prior to radical treatment at diagnosis, whilst I know PSMA PET scan is very affordable, can be done, but I would urge a little bit of caution because it could imply that you find one or two areas which are non-specific. We know that in the ribs, PSMA PET scan can give non-specific activity. Then you've got a patient who's 55, who's got a Gleason 9 prostate cancer, T2C, and you did a PSMA PET scan and you found two areas on the ribs which are of doubtful significance. Are you going to deny the patient radical treatment? And if so, can you imagine what you're condemning him to? I would say that actually look at the Stampede radiotherapy evidence, and I would be comfortable saying, look, I don't mind not detecting one or two sites of activity outside the prostate with a PSMA PET scan, because we don't know whether treatment for that with the PSMA PET scan detection actually changes outcomes. It may, but we don't know that. So I would offer a patient radical treatment, and if they progress, then do a PSMA PET scan. Now, if I didn't want to offer a radical treatment because I've got a patient who's 75, where I feel their survival, as we heard in the first talk, if their survival is not more than 10 years, 20 is difficult to calculate, but more than 10, and I'm thinking whether or not to do radical treatment, then I think doing a PSMA PET scan is more reassuring, because you can say, look, there are sites of active disease. Let's put you on systemic therapy rather than you going through surgery or radiotherapy with its anticipated side effects.
Yeah, okay, please go ahead.
The question that you've asked, which is going to disappear, I think M0 CRPC is going to become smaller and smaller. It will not disappear, but it will become smaller, because even though I have said in meetings, and I keep on saying that it should be labeled M micro CRPC rather than M0 CRPC, we do find that in a small proportion of patients, there is recurrence in the primary after radical radiotherapy and no site of metastatic disease. And salvage treatment options are not always useful because of the significant side effects. So M0 CRPC, I think, will become a shrinking field, but will not disappear. You're absolutely right that is there an overlap between oligomet and MHSPC low volume? Of course, but the low volume definition is not based on PSMA PET, as you know.
Yeah.
And you and I know, and I'm sure you have patients whose bone scan probably was clear, but PSMA PET has shown more than 10 areas of metastasis.
Yes.
Yes. So I think, I'm trying to help Dr. Mohammed, because I don't think it's an easy answer to give.
Yeah, I know.
Technology can be a friend, but technology can be very, very disconcerting as well.
Yeah, it's a nightmare. So, because of our colleagues, young staff colleagues, young juniors, our junior fellows, if you agree on what I am going to say, please vote yes. If no, say no, no hard feelings. Okay, and it will be a debate.
But then you wouldn't give me nice dinner when I come back.
You will have it always. Don't discuss about this. Okay, when I have a patient with negative conventional scanning, and then I'm going to do Bisma scan, and I will find 1, 2, 3, 4 lesions incidental in the Bisma scan, this would be the terminology of oligometastatic.
Yes.
And if I have the same, but evident on conventional imaging, this would be the low volume metastatic disease. And forgive me, I played this way for the introduction of the apalutamide in Egypt, and I was the man who conducted the launch, okay? But believe me, I am not convinced at all by any of them. Because when you go to the literatures published after the trials for the INZA and apalutamide, and even for the Aramis, you will find that 50%, more than 50% actually, of patients included in the trial, they had positive Bisma scan.
Yes.
While they were negative in the conventional one. So forget about the M0 CRPC, there will be a long debate. Do you agree that if we have negative scan, negative conventional, and positive Bisma for 1, 2, 3, 4, as you want, this is a disease category? And if we have it on the conventional imaging, this would be another disease category.
I think I would agree with you, and I don't think I'll ever be brave enough to disagree with you, but I will put a caveat to that. That actually the definition of oligometastatic disease, when it was originally done, was based on the imaging that was prevalent at that time. And PSMA PET scan was not prevalent at that time. But what you're saying, I am in agreement with what you're saying, because we need to refine our definition of oligometastatic disease, and just basing that definition on conventional imaging would be wrong, because you treat one site of oligometastatic disease with SABR or even surgery, say, but you'll soon find other sites coming up. Whereas with PSMA PET scan, you are a bit more reassured that other sites, even if they are there and not showing up, will take a bit of time to show up. You know, eventually this is a seed and soil theory, basically.
Yeah. You
but
know,
I will say one thing about M0CRPC. I urge my registrars not to do PSMA PET scan in a patient who is M0CRPC on conventional imaging if their PSA doubling time is less than 10 months, because they require systemic therapy more than stereotactic radiotherapy. And if you show metastasis on PSMA PET scan, which we know will happen in 50% or 60% cases, you lose the option of using apalutamide or darolutamide in that setting, because then you are in MCRPC setting and you then only have the choice of ABI or ENZA, and you probably won't give chemotherapy for someone with very small volume metastatic disease on PSMA.
Yes. As you know, from the last ASCO, I've just seen this presentation today. I don't remember the presenter, but the data was to omit the use of the isotopic PON scan from the prostate cancer and to go for BESMA scan immediately. Do you agree on that?
I don't actually on that. And I'll tell you why. I will agree once we have a prognostic measure based on PSMA PET scan. I know the bone scan has come into disrepute and a lot of people are saying, let us just forget it. But the prognostic classification based on bone scan, low volume and high volume, is based on data on bone scans. I have not yet seen a prognostication from PSMA PET scan. Do we know whether in a PSMA PET scan 4 spots or more than 4 spots makes a difference, or is it 10 or is it 20? How do we classify that?
Yes. There was a definition, I think, by the MSK, by the Memorial or the MD Anderson, that they considered that the cutoff point for the oligometastatic disease was 10 in number. I was astonished and frustrated from this one. So when you are going to consider a patient with high volume.
Yes, I want to comment here. I agree totally with Dr. Muhammad Abdullah that we have two different entities. We have low volume disease and we have oligometastatic disease. Actually, we have different definition also for the low volume disease. We have the definition of HORAD study, which play a role in the radiotherapy, local irradiation in patients with low volume disease. And they defined not oligometastatic low burden disease at less than 5. So it's different definitions, and none of any of the trials addressing the low volume or oligometastatic depend on the BESMA scan. So I agree that we should go for BESMA scan, but with very cautious, because we can put the patient on palliative treatment, on only palliative treatment based on something like 2 or 3 BESMA positive scan, while the patient will go with radical treatment if we depend on the conventional imaging. So the prognosis of the patient will be very, very different if we go for radical. Yes, I can go for BESMA scan before radical surgery, yes, because it's very invasive, especially in patients with old age and questionable performance status. But for definitive radiotherapy, why BESMA scan? We don't have any data right now to classify patient according to BESMA scan. So yes, BESMA scan is very optimistic option, but till now it's not valid actually.
One day I was with Professor Tombal, and he told me that Dr. Motey, Nicolas Motey, he is refusing the oligometastatic disease, but because it's not there in the guidelines, in the established guidelines. But Dr. Tombal refused this, and he insisted that we have to consider oligometastatic disease based on the metabolic scanning that's not shown in the conventional imaging. This is why I had the conflict.
Actually, I have one question, and it's for all the panelists. In your clinical practice, when you are confronted with a case of oligometastatic prostate cancer, first of all, are you convinced that this is a special category? And the second point, what are you going to do? Are you going to send it for complete eradication of the metastatic sites by radiotherapy or what? Yeah, I think it needs to be discussed. Is it really a category which is present? It is not present in the guidelines.
Yes.
Yes. And the percentage of patients who are presented with this disease, oligometastasis, is not a large percentage of our patients in the real life. Yes. I think my opinion is to go for the PSMA scan for the patient who you want to push away from the definitive treatment or the definitive local treatment, I mean. So as Dr. Amit said, we should look for the patient, the age of the patient, the expected survival.
Yes,
and if the patient is pushing you for local treatment and you don't want to do local treatment, do PSMA scan to push him away from definitive treatment. But if the patient is young, good general condition with oligometastasis in the conventional scan, I think we should avoid PSMA scan, not to push the patient away from the local treatments. I don't know if you agree with me or not.
Yes.
My professor, in this situation, we have different population in the metastatic castration sensitive even. We have some patient relapsed after local treatment, and we have the other side, patient de novo metastatic disease. I think it's completely different prognosis and behavior. So if I face a patient after local treatment from 2 years or 3 years ago with single lesion or 2 lesions, I think I will not proceed for bismuth scan. I will treat him as oligometastatic disease. But it's because the prognosis of this patient, I think it's very good and suggests that it is oligometastatic disease. But you know, we will discuss in de novo metastatic or relapsed early after local treatment.
I completely agree with you. Yeah. I completely agree with you. Last meta-analysis showed that this duration between the end of the primary treatment and the evolution of the metastasis is having a little bit effect on your decision in treating the patient. Yes, completely agree.
Yes.
I think the oligometastatic disease now as a special entity, we are going to face it more and more than we are facing the RPC because we are searching for.
Yes.
We are also should correlate the level of the PSA with the metastatic event and the. So in your clinical practice, Professor Muhammad and Dr. Amit and the board, in your clinical practice, what you do with some patient receiving a charted trial protocol in the first line, and the PSA didn't achieve the best level within 7 months. And I have some patient 8 months after docetaxel treatment, and the PSA is still 6, 7, didn't reach to undetectable level. From data from ARCIS and the enzyme trials, the subgroup of patients receiving docetaxel with the hormonal therapy in the first line didn't achieve any clinical benefit in the arm of docetaxel. So you can wait for the current trials for triplet therapy, or you can give something more to those patients, or only observe this patient.
I think we will observe until they progress.
Yes, this is a lost patient by any means because he is having a very aggressive disease, and if you are going to leave him for a couple of months, he will flare. So wait. I do agree with Ahmed a lot to wait so far that the patient is asymptomatic.
We have a question from one of the attendees, Dr. Lub. He is asking about it will differ if the metastasis in the axial skeleton or the non-axial skeleton in the definition of oligometastasis. I think one of the attendees asking this question.
No data about that.
Oligometastasis, no, but low burden and high burden, yes. There is no data about oligometastasis, but yes, it differs in low volume disease.
Definitely.
If we have the definition of high volume disease, we should have 4 or more bone metastases. One of them must be outside the axial,
outside the axial,
or visceral metastasis, or both. any unlimited, if the patient have unlimited number of metastases, provided that they are limited to lymph nodes and axial skeleton, it's low volume disease.
I think
that about oligometastasis actually.
Yes, definitely. But I think also there is a sharp demarcation between patients not seen in conventional imaging and those detected in plasma scan. I think both are two different categories.
Yes, of course.
Irrespective of the site.
Yes. Thank you all for your festival discussion and your insight. Now, we will shift for the second session. I have the honor and the pleasure to introduce our star speaker today, Dr. Muhammad Abdullah. Dr. Muhammad Abdullah is a professor of clinical oncology at Al-Ain University. Dr. Muhammad will present metastatic castrate-resistant prostatic cancer current treatment. Dr. Muhammad, please.
Thank you, Professor Lubna, a lot. I'm not the star. Our star today is Amit, definitely.
We have more than one star.
He's the Jean premiere of tonight.
Yes.
And today is the weekend, so we should have a Jean premiere, and I'm definitely the Jean premiere. Thank you very much, Lubna. You are my sister and colleague. We have a long time together, and really, I do admire you. Now, my screen is shown?
Yes.
Okay. Again, I admire the kind invitation of EMOG, really, for inviting me for this presentation regarding the M1 CRPC, which is the counterpart of the metastatic hormone-sensitive prostate cancer. Hereby my disclosures, and I think we have definitely a growing insight about prostate cancer as the number of publications are shooting, as you see, between the start of the PubMed.gov, the PubMed in 1894 till now in 2021, and it was just one publication at the ancient time, but now it's approaching 20,000 publications per year, which means that we have definitely growing insight that's going to be translated into a tailored management of our patient and the better service for our patient. As we go for prostate cancer biography, its CV is really impressive because it's definitely a combination of highly prevalent and lethal disease, depending on the physiology, the androgen receptor signaling, and going to affect certain sector of the community needs special care, which is the elderly population. However, we have gold standard for patients considered for management that we need to have a prognostic validation for their group or for their situation based on the Gleason score, those above 10, below 10. Do we have clinical progression at presentation or not? And the duration from the and the response for the first androgen deprivation therapy above or below 12 years. And then definitely the shooting levels of the serum BSA would be the gold item to be considered for those patients. And as we see here, we have, whether we are talking about a univariate, multivariate analysis, we have significant correlation with such variables. Again, it's really a global view, as the prostate cancer is the third worldwide regarding the incidence and ranking the fourth among the cancer-specific causes of death. In Egypt, we have, it ranks number 5 among males. So this is really a big deal, and we need to have some better insight to offer our patients better service. Don't focus on this big cartoon, but this is our target, the androgen receptor signaling and its abnormalities. I'm not going to say mutations, I'm going to specify abnormalities, because if we have effective castration of the patient, but still we have disease progression, it means that we have a playing enemy in the backstage of disease going to affect the outcome of the treatment, or we have something in the structure of the androgen receptor itself. When we go to the known genomic alterations in the metastatic castrate-resistant prostate cancer, over 70% of patients are going to have abnormalities in their androgen receptor pathway. Assuming this is one of my oldest slides, this is the cell membrane, the first line. The second line is the nuclear membrane, and the area of the DNA, this is the area containing the androgen responsive element, which is responsible for the growth of the normal prostate and at the same time the progression of the prostate cancer to later disease stages. We might have first a polymorphism of the androgen receptor, and the androgen receptor, it's a protein, so it's a peptide or formed of certain number of amino acids. When we have an abnormality and this number is too short, it's going to be tightly binding to the receptor, leading to continuous stimulation, and in turn will stimulate the androgen responsive element continuously. Another factor, which is a mutation. As you know, that androgen receptor is one of, with other 5 members, constituting the supernuclear family, steroid family. It comprises the androgens, progesterones, and others. So when we have mutation of the receptor, it could be stimulated by the other members of the family. And this is a promiscuous way because it's not depending on the androgen. Finally, we might have an amplification that despite of the effective castration, we might face a state of amplification. We have a lot of the receptors, so it will soak for the androgen traces present in the circulation going to be stimulated. And in all 3 scenarios, there will be stimulation of the androgen responsive element, leading to evoking the full malignant potential. The first and the third could be called the hypersensitive pathway, while for the mutation, this is a promiscuous pathway because it depends on other members, not the androgens, for stimulation of the androgen receptor. This is the androgen receptor splice variants. As you know, that the androgen receptor is composed of 4 parts. The nitroterminal domain, which is constitutively active, and it doesn't need the presence of the androgens to be stimulated. Then the ligand binding domain, where the androgen is going to bind with the receptor, to fit with the receptor. The DNA binding domain, where the activated receptor going to have some ligand with the nuclear chromatin to stimulate the androgen responsive element. And finally, the hinge, where we have a translock between the activated receptor and the nuclear membrane before going inside the nucleus to do the full action. Here we have in the androgen receptor splice variant 7, this is the most commonly encountered. As you see, we are lacking the ligand binding domain. So the receptor will be activated irrespective of we have androgens or effectively castrated via the ADT plus or minus any other androgen receptor blockers. Then we might have the backdoor synthesis of the androgens. As you know, we have a main source of androgens, the testicular androgen and the adrenal androgen. Here, inside the prostate cancer cell itself, and through the stimulation of the cytochrome 17A1, we will have progression from pregnenolone to a final product, which is the dihydrotestosterone, which is the activated product. So if you are going to castrate your patient effectively, surgical or medical, still there is a significant production of testosterone or the androgens inside the prostate cancer cell itself. So it's defined as androgen self-sufficient organs. So you have to keep an eye on this. Also, we have the microtubule, which represents the transportation vehicle for the activated receptor in the cytoplasm to be transferred into the nucleus. And this could be also another target to act upon to block the androgen receptor signaling. This is the story of the prostate cancer, different chapters, different phases, starting from the localized to the biochemical failure, and then metastatic hormone-sensitive prostate cancer, metastatic castrate-resistant prostate cancer, till the end, where we will face the monster after effective castration, which is a really not only hormone refractory, but it's rather a hormone indifferent disease. As we have better achievements in our practice, tackling every stage of what we have, so looking to prostate cancer as a story, we need to add more chapters to make the survival of the patient or the overall survival outcome to be improving. Here, we have the M0 CRPC defined as rising of the BSA on ADT, and we will go to this definition after a couple of slides, with negative radiographic evidence of metastasis and the effective castration. Also, we have the metastatic hormone-sensitive prostate cancer, comprising actually three parts, three main items: the oligometastatic disease, low volume, and the high volume. They will proceed thereafter. Androgen deprivation therapy will continue throughout the spectrum of the story. But earlier in the course of disease, in the localized or patients with biochemical failure, we can depend on the ADT alone plus radiation therapy, either to the primary or to the metastatic sites, the oligometastatic sites, irrespective of the definition. We are talking about the concept. Then, when we consider the metastatic hormone-sensitive prostate cancer or the metastatic castrate-resistant prostate cancer, we need to improve the quality of the castration. We need intensification, and here we have a lot of arrivals for this. We have the ARTA, the abiraterone acetate, enzalutamide, apalutamide, plus docetaxel for patients with high volume of disease. Then we move to the hormone indifferent or the real hormone refractory disease, where we started to have other chemotherapeutics like cabazitaxel, or we have identifying some of the molecular events encountered in the backstage of disease requiring special attack, like those with PARP inhibitors, as we have this now established in the guidelines for the management of a specific entity of the prostate cancer. For the M0, and we are going to hear it soon, we have 3 agents approved for this, the ABA, INZA, and darolutamide. Definitely, when we proceed, we will face more and more tumor burden, and definitely this will be reflected on the patient symptomatology. CRBC actually is really important one, because for a long time we did not have effective therapies. And it was found that 10 to 20% of men will develop CRPC within 5 years of their diagnosis. And if we are diagnosing now a patient with CRPC, 85% or more are going to have bone metastasis, and if they are M0, over 30% will develop bone involvement within 2 years. The survival before the era of docetaxel was about, median survival was about 14%. Regarding the definition, we should offer the patient or ensuring that the castration level is perfect, below 50 nanogram per deciliter, plus one of either the biochemical progression, depending on 3 constitutive rises of the BSA 1 week apart, resulting in 2 more than 50% increases over the nadir of the BSA, and the BSA should be higher than 2 nanogram per milliliter. Or to go for more technologies of investigations, the radiographic progression, whether we have newer lesions while on effective castration, 2 or more bone lesions on bone scan, or soft tissue lesion, while considering the symptomatic or subjective progression not included in the terminology. So, if we need to summarize our situation now and the role of ARTA or other therapeutics in improving the castration quality. As I said before, and as you know definitely, the core is the effect on the androgen responsive element based on the ligand between the androgen and the androgen receptors, leading to prostate growth if we don't have malignancy really, or the cancer progression. Testosterone, as you know, coming from the gonads or the adrenals, where surgical and the medical castration would be quite effective in controlling the disease for a while. While if the androgen receptor is having a normal activity, this would be the golden era or earlier era of the androgen receptor blockers, the first and second generation blockers like the bicalutamide. But when we have abnormal activity or overactivity of the microtubule or the presence of androgen receptor spliced variant 7s, or we have activation of the self-production of the androgens within the prostate cancer cell, here we need to improve our approach, because this will be the causes of failure of our treatment disease progression that inevitably will be fatal. And we have here the third generation androgen blockers, the INZA, ABA, and their upcoming DARO for abnormal activity of the androgen receptors. We have taxanes to control the microtubules, to stabilize the microtubules so the activated receptor would not be able to go to have a translock and to shuttle inside the nucleus to stimulate the androgen responsive elements, while we can effectively control the phenomena of androgen self-sufficiency of the prostate through the abiraterone acetate. And as the science and knowledge is growing, we have the genomic alterations and biological pathways of growth encountered inside the cell. We have the PARP inhibitors in part, trastuzumab initially, although it did not really contribute much to the management of the metastatic prostate cancer, and maybe the PI3K would have more and more indulgement in the management of this issue. So definitely we improved the castration quality. We had achieved improvement. And since the year 2010, as you know, docetaxel was introduced into our clinical practice since 2004, and really it yielded good job for the management of the castrate-resistant prostate cancer, metastatic disease, when compared to the mitoxantrone. But since 2010, we have a lot of agents, a lot of ways to tackle the disease. We have the ABI, INZA, before and after the use of docetaxel. We have the capacitaxel, and we have the alpha emitter radium-223 and its role in the management, although it is not available in our country. But all the trials, considered many or shared the same endpoints regarding the gold standard, the overall survival, the radiographic progression-free, PSA progression-free survival, as well for the pain and the quality, time to pain and the quality of life deterioration. But at the end of the day, the median overall survival was nearly doubled from 18 months to 35 months. But still we have a big problem. Why? Because when we look to the metastatic disease in particular, this will contribute a lot to the lethality of the disease, as the majority of patients are going to die from cancer, and still significant proportion are going to die from the other causes, deterioration of pre-existing condition or something like that. And the 5-year overall survival is quite disappointing. So we are talking about an inevitably fatal disease. And we have a lot of unanswered questions. First, do we really have a drug resistance that's responsible for the disease progression? What's the best drug sequence, as the head-to-head trials are lacking? There is no real knockout in the pharma market. Definitely, if we have a knockout, it will mean a lot to the company, to the people investing, and so on. Don't expect to have head-to-head comparisons a lot. What's the role of mutations other than androgen receptor signaling, and the impact of the patient's profile and drug class of toxicity on the compliance to the treatment, which will affect definitely the outcome. And definitely we have more and more questions to be answered. But when we go to the several meta-analyses and the data that was formulated from 10 years experience with managing CRPC metastatic disease, that we have actually subcategory of our patients where the BSA declines very steady, going to have a marvelous response, but this is not in the majority of our patients, as you see here with the green line curve. This is definitely the patient who is going to have prolonged, durable radiographic progression-free survival, which is very important here because it means that our patient will be at least kept free of pain and without deterioration of the quality of life. Followed by another category of our patients in blue. They first go down and then slowly rising PSA. So the response will not be definitely as durable as this group of patients. And about 1/3 of patients, they are going to relapse very rapidly. There will be no response to the ARTA used. This is what we learned from the enzalutamide trials. And when we talk both agents, abiraterone and enzalutamide, they were present in the market together for a long time before the advent of darolutamide. But still, we have a significant proportion of our patients going to show no response to the proposed treatments. As you see, the curves from the Cougar 301 and the Affirm trials, the two curves for the active agent and for the placebo are overlying each other. About 30, maybe 25, maybe more % of our patients are going to experience primary resistance to the proposed ARTAs. So the radiographic progression-free survival will be definitely deteriorating. So to go for another ARTA after failure of one, after failure of ENZA, to go for API, or to go for ENZA after failure on API, I think this is not really a wise decision, because when we go to a lot of trials over many years, the duration of the second treatment before saying no, there is definitely treatment failure would be quite modest, in few weeks to few months, on the best to go for 4 months. And the same for the ability to control the BSA decline more than 50%, as well for the median progression-free survival. So to go for docetaxel, for example, if not used previously in the earlier stages of the disease, like the metastatic hormone-sensitive disease, actually also this is not a good choice. Why? Because we have a limited activity in post-abiraterone failure, for example. It's lower than anticipated when used upfront. And for patients showing no response or abiraterone refractory disease, there will be no response for docetaxel administration, as you see from this waterfall cartoon. But still, we have another one, which is the cabazitaxel. It has definitely retaining some activity following failure of either docetaxel or any of the ARTAs used. Again, to be impressive in the survival outcome, you need to integrate all your weapons. 3 is better than 2. 2 is better than 1 modality or 1 attack of therapeutics. As you see, this is the median overall survival achieved for several combinations. The best, when we consider the overall survival from the onset of diagnosis here, you can notice that to start with the ADT, that's going to continue going for DUCI, followed by Capazi, followed by ARTA. The median overall survival would be 53.9, followed by just substitution to shift the Capazi behind ARTA. But the same, we are using 4 drugs. And definitely both of them, the 4 drugs with Capazi before ARTA or ARTA before Capazi, were associated with significant improvement of the median overall survival, as if we are restricting our approach to chemotherapy only. Docetaxel and the Capazi median survival is quite low, 38.3 versus 44.4 and versus 53.3. And when we go to stratify the survival from the diagnosis of the onset of metastatic CRPC, the same findings were confirmed. So we are telling really a real event that when you go for ADT from the start and the continued, followed by docetaxel Capazi Arta, is slightly better than docetaxel Arta Capazi, but definitely away from docetaxel to Capazi only. When we need more data, we are talking about not prospective trials. We are considering meta-analyses. So we need to emphasize, if we find the same finding from other retrospective meta-analysis, this will be adding some strength to our practice. Here, data published in the European Urology Oncology in 2018, randomizing or analyzing patients with different treatment scenarios. Group 1, docetaxel, cabazitaxel, followed by Arta. Group 2, docetaxel, Arta, cabazitaxel, the same like the previous scenario. And the Group 3, starting with Arta, followed by Doci and Capazi, as there is no way to start Capazi before docetaxel. What we have for Group 1 and 2, nearly the curves are overlying each other. It means that to go for algorithm like Group 1 or Group 2, it makes no much difference. But definitely, when we go to the third one, for the Arta, docetaxel, cabazitaxel, without characterization of the patient group, definitely the survival outcome would be somewhat lower. And they concluded that predictors of worse survival outcome among patients with metastatic castrate-resistant prostate cancer includes the presence of visceral metastasis, the presence of pain, poor performance status, and to go, astonishingly, to start with Arta, followed by docetaxel, then cabazitaxel. This is against, definitely, the data coming from the real-world practice, as the majority of the clinicians usually prefer, as well for the patients also, to go for the oral treatment first before and trying to avoid the use of systemic treatments. More precise data came from the CARD trial. This one is a prospective one, comprising an adequate number of patients, randomizing patients following failure on Arta, plus or minus docetaxel, to go for cabazitaxel plus prednisone versus abiraterone or enzalutamide, based on what we had primary in the earlier treatment lines of the disease. Primary endpoint was the radiographic progression-free survival, and the secondary endpoints were the overall survival and a lot of other items. Here what we have, the radiographic progression-free survival definitely improved, favoring the use of cabazitaxel other than the Abi or Enza. And the outcome was nearly about to be tripled, 8 versus 3.7, with extremely impressive hazard ratio 0.54 and extremely positive p-value. And when we go to the subgroups of patients, it was favoring the use of cabazitaxel other than the newly introduced Arta. For the overall survival, it retained the positivity. It retained the positivity in favor of to go for Capazi after Arta for plus or minus docetaxel previously. Progression-free survival shared the same positivity, favoring the use of cabazitaxel. I know we have a lot of data, we have a lot of trials, we have a lot of insights, and definitely there will be no unified algorithm for the management across the continent. But late in the year 2020, I had found this algorithm for the management of patients with metastatic castrate-resistant prostate cancer published in the Therapeutic Advances in Medical Oncology, where we have about 12 of the distinguished uro-oncologists, and they had a panel to discuss certain questions, trying to formulate the approach to the management of patients with metastatic CRPC. If the patient progressed after androgen deprivation therapy and docetaxel previously, then you are going to characterize your patient. If the time of progression is less than 6 months and or progression during the therapy itself, ADT plus docetaxel, and I think we had a question like this, the 14 or the 12 panelists voted to go for cabazitaxel. If it was a biochemical progression with poor performance status, and at the same time we have a history of poor tolerance to the previously received docetaxel, we can go for Abi or Inza. It makes no difference. If you have a patient with visceral metastasis, although we have data for the Inza for the presence of visceral metastasis in the trials, and they were excluded from the analysis for the Abi, for example, but the visceral metastasis favored the use of chemotherapy. If we have poor performance status due to the disease itself, you can judge to go for ARTA or another chemotherapy, which is Capazi in this situation. If you have a clinical or radiographic progression, we have to assess, we have to look for the backstage through further analyses. If you have an aggressive disease, neuroendocrine variants or something else, this is definitely going to be progressive despite of the effective castration. Here, you have to go for chemotherapy, definitely platinum-based combination. If patients progressed after Abi plus ADT, in general, you can go for docetaxel being not used before, but if you have a symptomatic disease due to the bone mets without visceral mets, without high volume, or failure to 2 treatments previously, you can go for radium 223 as an ideal option for this patient. Here, we need to emphasize some points about the adverse events related to the treatments. We have different classes. We have chemotherapies and we have the ARTA. And as we said before, chemotherapy is chemotherapy. We do expect it to have mainly the hematologic toxicity of the agents used, and we are all acquainted with this, and definitely this is accentuated with Capazi and docetaxel as compared to the Inza or Abi. The hot flushes, definitely it's going to be more accentuated with Abi or Inza, the hormonal syndromes. While for the cardiovascular events, hypertension, cardiac events, and increase of the liver functions, I think this will be more expressed with the ARTA compared to the chemotherapeutics. The death due to disease, it was not really higher in the chemotherapy arm, maybe much lower, and this table obtained from the current urology in 2016. Another point, don't forget that you are talking about elderly with a lot of comorbid diseases, hypertension, cardiac, diabetic, other endocrinal disorders, CNS disorders. So they are usually on a hell number of medications. So don't forget to have your clinical pharmacist with you to tell you what about the drug-to-drug interaction. Here, for the ARTA, you can notice for abiraterone and enzalutamide, you can count the list of drugs having significant interactions with either of them. And definitely, this is going to be translated to either ameliorating or increasing or decreasing the effect of the drug or the other, the main drugs, the Abi or Inza, as opposed to they use the drugs for the treatment of other comorbidities. This is extremely important, hazardous, serious, and this should be taken into consideration. But for chemotherapy, I think you can count on the fingers of one hand that really we don't have much of the drug-to-drug interaction. This does not mean that because of this, we need to go for a certain medication and avoiding the other, but it has to be taken into consideration. So, in view of the available data, to go for chemo after chemo, definitely in the metastatic castrate-resistant prostate cancer, it's valid. To go for chemo after ARTA, yes, it's also valid. To go for ARTA after chemo,